Good evening. Thank you for joining us. If you are here for the Life Without Lead workshop, how physicians and healthcare providers play a role in lead poisoning prevention, you are in the right room. So thank you. For those of you that were with us this morning or throughout the day, thank you for hanging with us. And I hope that you were like me and got a lot of amazing knowledge and feel energized. And for those of you who are just joining us now, thank you. We are happy to have you. Just a lot of information covered today, and I know that those recordings will be available. So if you want to catch up, please do so. We've covered a lot of different topics within the lead poisoning prevention arena and how communities can take action. This session will focus on the role that healthcare providers and health plans play in dealing with poisoning and connecting families to resources when it comes to lead. My name is Karen Schaefer. I am the co-chair of the Lead Safe Allegheny Education and Outreach Committee, and I've been doing this work with Get the Lead Out and with Lead Safe Allegheny I just found notes from 2017, so it goes at least back to that far. And I'm also the clinical director with the Alliance for Infants and Toddlers. We are the service coordination unit in Allegheny County, and my role in this is that any child with an EBLL of 5 and above is automatically eligible for our at-risk tracking, and we also support CYF for children that are accepted for service, ensuring that they get developmental screens. And I've been a developmental specialist and a behavior specialist throughout my career, so I have a stake in this too. As we talked about in earlier sessions, and as many of you know, there is no safe level of lead. So even though what we recognize to be a level of concern or consideration at 3.5 has been the latest recommendation. We know that there is no safe level, and we'd love to get to 0, right, in our lifetime. But lead is a neurotoxin that can permanently impact the overall health, development, and well-being in children and adults. And it can be found all around us, particularly in a city with a rich industrial history that has a lot of old housing stock. It's everywhere. And we know that the primary sources are lead-based paint, dust, lead in drinking water, and in soil. And really what has been driven home to me today, and what I want to, really what we're going to talk about in some form today, is the fact that lead is a social injustice issue. It's also a barometer of the housing disparity and some of the concerns that we have in terms of health equity. Those issues are all something that have come to the forefront, I think, particularly through the pandemic, but I think it's also a strong consideration and factor when we're thinking about lead poisoning of our children. I think we can all agree that implementing prevention policies is critical to addressing lead poisoning. And I really think that we're still responding to lead poisoning, right? So we still have a problem. It's still prevalent. It's still a public health issue. And we really need all entities and all sectors to work together. So tonight we want to talk about the role of physicians and healthcare providers and what we can do to work together. I think this whole day has been about supporting each other, collaboration, finding our champions. We need our champions in the healthcare provider world, and I am happy to introduce the panelists this evening who are exactly that. First, we have Dr. Diego Chavez Nyeko. He is a developmental behavioral pediatrician, an associate professor of the University of Pittsburgh School of Medicine, director, founder of the program Salud para Niños at UPMC Children's Hospital of Pittsburgh. Diego's clinical and academic interests include diagnosis and treatment of children with autism and attention deficit hyperactivity disorder, providing care to families and children with disabilities, providing care to children from minority and underserved populations, and addressing barriers to healthcare access. And I will also say, on a personal note, he is a huge advocate for early intervention and works collaboratively with us, so we appreciate that work too. We also have with us this evening Dr. Kevin Osterhaut from Children's Hospital of Philadelphia. He is an attending physician in the Division of Emergency Medicine and the medical director director of the Poison Control Center at the Children's Hospital of Philadelphia. He serves as a professor of pediatrics at the Children's Hospital of Philadelphia and the University of Pennsylvania School of Medicine, and is a faculty member in the Community Outreach and Education Core of the Center of Excellence in Environmental Toxicology at Penn. That's a mouthful, Dr. Osterhaut. He has co-authored over 100 journal articles and textbook chapters and serves on the editorial boards of Pediatric Emergency Care and Clinical Toxicology. And last but definitely not least, we have Rebecca Vida. She is a licensed clinical social worker. She is a certified case manager and is a graduate of the University of Pittsburgh School of Social Work. She is the clinical quality management consultant within Gateway's Special Needs Unit, holds the title of EPSTD coordinator, and oversees lead programming at Gateway. Rebecca is active with Let's Save Allegheny, and she has been a co-chair for the Data and Research Committee since July of 2020. She is also a participant in the Lead Free Promise Project. So thank you all for joining us this evening. In 2018, just a little backstory for everybody. In Allegheny County, the health department implemented universal screening with requiring all children ages 1 and 2 to be tested for lead, and with the thoughts that children up to 72 months would have catch up. So we would hope that all children would have be tested for lead before their entry to kindergarten. As we have more screening data, we understand that over 400 children on average are being lead poisoned every year. So really, that's the equivalent of 20 to 22 kindergarten classes. Could you imagine being the teacher in that kindergarten class with every child lead poisoned? So we know that screening is required for children in Allegheny County, but we also know that we're only getting about 60% of those kids screened. So where are those 40%? Who are they, and how can we engage them? So I think those one of the questions we want to think about this evening. But really where I want to start is, and this is just something, my own curiosity, so I'm sorry I'm leading with that. What level of awareness do you feel that families have about lead exposure? I think a lot of people still think lead is from something in the way back, and they don't know that it's a prevalent situation. So, are families coming in asking about lead prior to testing? Are they concerned about those numbers? Dr. Diego, I'm going to start with you.
Well, I want to start by thanking the organizing committee, Karine, my co-panelists. It's an honor to share this event with you. We have made efforts with the LED coalition and with many organizations to raise awareness among the community. And while the awareness is increasing, we still have problems because many families, in particular our minority families, actually families who are exposed to high risk, don't have the knowledge that they need to have about this current concern. The other problem is that if they are aware about that lead is a problem and lead exists, a lot of times they don't have the resources to address the issue. A lot of times they live in housing that is rented housing, and I know this is a topic that has been addressed through this meeting, but also the fact that sometimes even access to healthcare is a problem. And this is something that we're going to be talking later. But when the Allegheny County made the mandate to have these lead levels, one of the things that it was left up on the air, not completely resolved, there were some solutions, was what to we don't insure kids. And again, this is something else that we're going to be talking. And finally, another concern that we have currently is the fact that we, unfortunately, because of the pandemic and because of the decrease in the workforce, we're having difficulties to screen everybody that should be screening. So bottom line, to answer your question, we're making strides. We're raising awareness. Meeting like today's meeting, which I understand has been a very well-attended event and well-received by the community, helped to increase awareness in the community. There is still a lot of work to do, and there is still a lot of work to continue doing. So thank you for having us, and thank you for all the work that everybody is doing around this.
Yeah. Kevin, I'm going to kick it off to you on the other side of the state. What is your family's level of awareness, and how are those conversations going when you're having them? Like how is that happening?
That's a great question. I think that awareness of the problem of lead tends to run in communities, and there are some communities where the word has gotten out and that people get to know about it, and there's community action, and there's other communities where the word probably hasn't gotten out to the same degree as Diego had mentioned, I think that there are problems with access to care and problems with hope and the ability to change your environment or your living conditions that can affect how it's received. And the other challenge with lead at low levels, right, is like many other illnesses like high blood pressure that we know is a horrible adverse health detriment, but then on a day-to-day basis, you don't feel or you don't see. Lead can fit that realm too. And so as people prioritize what the issues are in their lives, sometimes lead doesn't come to the forefront the way that people on this call today are trying to bring it and to get it received.
Thank you. Rebecca, what are you seeing in I understand once the kids have already been identified by the time that they come to you. So kind of what are those conversations like from your view? And you kind of bridge both ends of the state, right?
Yeah, we do bridge much of the state. However, shockingly enough, many of the families don't have a lot of understanding. Even after they've been identified, they don't really understand where it's coming from or what it even means to have an elevated blood lead level. There are access issues. So even if they have had that elevated blood lead level tested, getting the retest done, because oftentimes it's done as a capillary draw, or the physician office may not have given them much information, or may not have even relayed the information of the test result to them yet. And sometimes we are the first call to them, giving them that information. So there's a lot of kind of upfront and groundwork that we have to lay with the family and relaying that to them to ensure that they have that understanding of what does this mean for my child as well as my family. And we had some of that talk earlier in the day about what does this mean for the household too, and that you may have one child that tests high, but their twin or even older siblings were at that same age and they never tested high. So, but they're in the same house. So how does that, explaining to the family, how does that work and why would that be? So I think that there's a lot of challenges that we still face, even at these, what some people think are, well, they are low levels. And like Kevin said, they weren't, it's kind of insidious, right? So there aren't kind of always identifiers that the child is sick, or they're not maybe in the hospital, they're running around and they look fine now, but you see that problem later on.
Thank you. So if we consider those things, and I know we'll talk a little bit more about the barriers as we kind of move through our, kind of hypothetical case, but what is the first step that a provider can or should take when a child has been flagged with an elevated level? Dr. Diego, I'm going to kick it back to you.
So actually, I would like to start with a step before that, and it's how can our practices do a good job in terms of planning to screen. We know, for example, that in Allegheny County, we want to have at least 2 lead levels before age 2. So I will share a little bit what we have been doing in our practice. So for a long time, we were doing lead levels at 1 year and at 2 years of age. But knowing that a lot of the times our families, and in particular our families who belong to minority groups, have a hard time getting to a doctor, they have barriers to healthcare access. And we decided to move these lead levels a little bit earlier, with the discussion about whether having it at 9 months was too early, because a lot of times by 9 months, they are not necessarily mobile, they're just putting things on their mouth. Bottom line, we decided that routinely, and the well checker visits at 9 months and at 18 months, we were going to be doing lead levels. And then the idea was that if for some reason they miss the 9 months, or we cannot draw the blood for whatever reason it is, sometimes it's a hard stick, we will do it at 12 months, at 15 months, with the ultimate goal to have the 2 lead levels at 2 years. Now, that's in terms of most of the practices that we have, and that's in terms of kids we have who have health insurance. But they don't have health insurance, a little bit more tricky. We do have a free clinic, and through our free clinic, we offer the testing. And Rebecca already mentioned some of the barriers that we have when we do capillary testing. We're going to be talking a little bit more in a few minutes about that. But bottom line, this is part of routine screening, routine well checker visits, and then we get the call from the lab. Usually the lab call us with elevated levels that are considered absolutely abnormal. But by the way, it has been mentioned already today, and it will be mentioned throughout these days, that there is not a normal lead level. So sometimes when we have a level of 2 or 3, then it might not be called by the lab. So it's the responsibility of the physician to check those results and then to address it to the family. Some doctors take the practice that, if the level is not absolutely abnormal, that requires some action from our part, we're not going to call the families and we'll let the families, if you don't hear from me, maybe it's because there is no action to take. Again, there is not normal lead level. But bottom line, there has to be some kind of communication with the families to tell them, in particular, when there is some type of action that needs to happen. And usually the actions that need to happen is, of course, refer to early intervention. In the case of Allegheny County, the Alliance for Infants, but also to start planning for what is the next step, how we're going to mediate it, how we're going to find where the lead is coming, and then finally how we're going to follow with this. So depending on different guidelines, we might have follow-up visit at 1 month, at 2 months, at 3 months. And personally, and many of my colleagues in my practice, what we like to do is when we make that call, we go ahead and actually schedule the next appointment, which will be in 1 to 3 months, depending on the lead level. That's what happens in the ADA world. As I mentioned before, there are barriers. If the kids don't have insurance, we have to go with capillary, and we're going to be talking about capillary problems, capillary testing problems. If the kids don't make it to the appointment, that's another issue. And again, currently under pandemic, we have a lot of difficulties with our workforce that is limiting the testing. But in the ideal world, that is what it has to happen, and that's what we want to follow, those lead levels.
Kevin, do you have anything to add to that in terms of like what your steps are, or how you manage things with your practice and the work that you do?
Sure, Karen. I guess if there's one message I could get out, it's one that I use with my students and my trainees and my clinicians all the time. When faced with a child with an elevated blood lead level, there are 3 priorities in their treatment. Number 1, prevent further exposure to lead. Number 2, prevent further exposure to lead. And number 3, prevent further exposure to lead, right? So when you're in that point, the first thing you want to do is do an environmental assessment. Is the child in a safe place? Do I need to do something to make that child safe, or to assist that child in finding a safe place? And then figuring out what the next steps are from there. So when you look at all of the CDC guidelines and the Allegheny County High guidelines and things for all the blood lead levels, they'll have that line in there that says, do an environmental history assessment or something like that. And then at some points they say, actually do an environmental investigation of the home. And I think that's the challenge for a lot of the people that are probably on this segment is that disconnect from being in your primary care practice to say, boy, how do we reach out there and work on the environment in the home?
And Rebecca, that's probably a good segue for you, since that really taps into a lot of the work that you do.
Yeah, and I would echo that. And I think that is the biggest concern that we have for the members, is to ensure that they are not being further exposed. As soon as that child has a venous level of 5, the first thing we want to see is an environmental lead investigation of the home, or wherever it is they're spending their primary time, because knowing that there's further exposure is just going to make the problem worse. So we want to get that investigation done as soon as possible. The first step is getting the test done at the proper times. The earlier, the better. So as soon as they're moving around at that 9-month mark, and then again, that second test is very important. But as soon as that venous level indicates that it's elevated, even if that test says it's 5, that's elevated, or 3.5, we'll be adjusting for that now. We want to get that investigation done. And if that investigation says the primary home isn't where the lead's coming from, then we take a step back and reassess to determine, okay, so where else are they spending time? Is it grandma's house? Because we have found that grandma's house may have a leaded coffee table in it. So we'll take a step back and look and do that next investigation, because we found some really crazy things in other people's homes that they spend time at that has been the cause of that problem. But the idea there is to make sure that this child is not having that additional exposure, because that in the long run is what ends up putting them in the hospital or having prolonged exposure, even at low levels, is going to cause significant problems or raise the level higher. And we don't want to see that.
Thank you. I think, my many years of home visiting and early intervention, and I'm a developmental specialist and behavioral specialist by trade and design. I think the hardest thing is to help families understand kind of the intersection of all those things, because this has come up earlier where, as you said, maybe one child, tests higher than another child, just depending on their development, their level of curiosity, their level of the need to put things in their mouth. You just don't know. I think some families don't understand. I've had conversations with grandmas that have said, oh, he used to have lead and now he doesn't. And you just say, oh my goodness, he doesn't need this anymore. And I'm like, well, it's still there, but it's gone hiding. And I think that's sort of that conversation to kind of keep normalizing this and talking about this. And I think, personally, the conversation needs to start earlier, right? Like at that 1 month, 2 month visit where you begin to talk about like that environmental stuff. And it's been a long time since I've been to the pediatrician with anybody, but, I think that's also part of it. We don't want to wait till 9 months to find this out, right? We don't want to, I think that's what's so alarming when when my kids were young, I'd think, oh, it's just, you get the lead test, whatever levels are good. But even if they were iffy, it didn't occur to me that they were already exposed. And I think that's the part that families often don't understand. And
that's such an awesome point, right? And, when we do a test at a year and we catch a kid at 12 months with a high blood lead, there's always a little voice in me saying that we were 21 months too late for that family, right? And really at the point when you're finding the place that you live, when you're planning your family, if we could all get our wish list, it would be finding a way to impact the environment at that time, right? Getting all the lead out.
I cannot agree more with Dr. Kevin. We talk about, for example, how postpartum depression transcends from the OBGYN and is now going into the pediatrician's area because we're the ones who see the families and the kids more routinely. I will make the same analogy with lead. Lead is usually cared by pediatricians, but actually it should be thought even before that. It should be thought in prenatal care. All BGYNs should be talking about this with the families. And what Dr. Kevin was mentioned, this should be part of the planning of having a family, deciding where to live. Of course, in the current circumstances that we are, in particular in cities like Philadelphia, like Pittsburgh, it's really difficult, and in particular for minority families, to have the luxury sometimes to choose these options. But yet, it has to be part of the conversation, and families has to be aware that this is something that they have to take into consideration.
I mean, we've all heard stories of children, if there's lead in the water and mom is making baby bottles from the faucet, right? And, I think those conversations, like if you're not asking the right questions, you're not going to get to the right answers. And I think that's like, you're right, that has to happen further upstream. Like, when a woman is, of that childbearing year and you're talking years and you're thinking about starting a family, or you're not, you're in that zone where you want to have that healthy community conversation. So yeah, those are all good points. Rebecca, do you have anything to add to that?
I would just echo everything in that, in particular that, we do send education and push that, especially if we know that there is a with our maternity program, we do talk about that, and the maternal home visiting programs also address the lead strategies prior to the child being born. And those maternal home visiting programs do focus on first-time moms. So I think that we are heading in that direction. We're not quite there yet, but it's starting to get in that direction now.
I think if we keep having conversations about healthy communities for all members, you kind of hope you cast that very wide net, right? And you catch everybody. I mean, I realize these are targeted to the folks that we know are most vulnerable, but really when you pull back, you really want to have it for everybody. Like everybody should have a lead-free environment, a lead-safe environment. Everybody should be in that situation. So yeah.
And if I make a plug about that, look how important is the role of health insurance. Rebecca just mentioned how they can be the connection between the family who's planning to have kids and that possibility of being exposure to lead. And unfortunately, we have many people in Pennsylvania who are uninsured, and that would be another thing that we need to address. You know, in the ideal world, we want to make sure that everybody has healthcare access, that everybody has health insurance, and through the partnership with health insurance, like Rebecca mentioned, that we can address the needs for these families.
And I think that leads to when, in addition to that, then you have, we are always say, one of the things they say about Allegheny County, and I don't know how it is over in your end of the world, Kevin, but we are resource rich, right? We are always told we are resource rich. We have all these opportunities. We have, yet a lot of things are so underutilized, or maybe the people that just meet the cutoff don't have access to the things that they need. I think that can be problematic. But how, if we have so many resources in place, we have so many families that could potentially be impacted, a lot of times we just don't have people that are engaging with services, right? So even though we know we are testing 60% of the children and we might identify 400 children, if we look to see the numbers of families that are actually fully engaged in the services of any kind, right? My service, our early intervention, the housing services, some of the things that could be supportive, things drop off. So how do we, up that community engagement, and how can you as, medical providers in that profession kind of support people in helping them to access those things?
So, I was mentioning the issue of health insurance, and right now there are about 24,000 children in Pennsylvania who will never qualify for health insurance, either Medicaid, CHIP, private insurance. They will never qualify. And there is an initiative at the state level to change the legislation so every children in Pennsylvania for sure have health insurance. Pennsylvania is behind compared to other states. Illinois, Massachusetts, California, New York, they truly have universal health care for all children. Having health care is one of the first steps to address barriers to healthcare access. Then we need to make sure that the information is provided to the families in the language that they speak. We want to make sure that if we're talking about lead, that we have the resource available in other languages. We have many languages that are spoken in our country and our state. We need to make sure that the clinics are available to see these patients. A lot of the times families have the insurance and they might have the ability to communicate with the providers, but they don't have ways to get to the providers because there is no transportation. And again, I know this is something that insurance companies can help us. Right now, through the pandemic, we have been able to get rides to the doctor. This is something that we should think about for the long term. How can we address all the barriers to healthcare access? Because at the end, any barrier that we have to healthcare access is going to prompt these families, is going to put these families at risk for high levels. Because if they don't get the information in advance and they don't get a screen on time, then they're going to be at high risk.
Yes. all the things. I think it's a very daunting problem. So I think sometimes if you scale it down to, what can you do, or what can the people that do the work that you do, right? And I think, we do have a resource guide that I'm going to pull Taylor, who's in the background somewhere, to put up in the chat for resource guides to helping children that are exposed to lead. And I think considering how to make that accessible, I think, Diego, you had some great points. The face of our country, our communities are changing. More people are coming from different places and have different ideas about, medical care and treatment, access, languages, all of those things make a huge difference. And it's been brought up a couple different times that sometimes the source of lead, as Rebecca had mentioned, comes from something unusual, right? We know we have a community, like a Nepali community here that has been growing. They lived in housing that, was certified to be lead safe in those situations, but it was a spice that was imported. So I think, and I had the humiliation of going to an event with Dr. Diego, bringing toys that had lead in them. Who knew, right?
No.
Because, yes, I will out myself. It happens, right? So, but I think those are the things that you don't think about. And I think that our first speaker spoke well to that, to say, when you have things from dollar stores and places that, kind of are targeted to, yes, the ducks, Taylor, that are targeted to low-income communities, they're often imported, that the regulations may not be as strict. So you may have done everything you could in your own home to take care of that. And yet here's baby, right, chewing on the head of a rubber duck that is full of lead or lead paint or costume jewelry, those things, mom kissing you with her lead and arsenic filled lipstick. Like those are the things that I never even considered until I started to do this work. So based on the things that we've already touched on and discussed, I kind of want to walk through some potential cases and kind of how things might be managed differently or suggestions that you might have. Let's say we have 3 14-month-old children and they've all received an EBLL diagnosis of 11 micrograms per deciliter. And let's say that one child is privately insured, one child has Medicaid chip, maybe one child is under Rebecca's umbrella. They have Gateway. They're with Rebecca. And then the other child is uninsured. So how do things look? How do those 3 trajectories for those 3 kids look differently from each other in terms of testing, confirmation, access? And I'm just going to throw it out there.
So one of the biggest differences, again, we're talking about access to healthcare, is when you have insurance, whether it's private insurance or Medicaid, you might have access to a clinic. When you don't have insurance, you have to try to be more creative, and your options are either federal qualified centers that have sliding scales or free clinics, which is still a very viable option in many parts of our state, in particular in Philadelphia and in Pittsburgh. However, part of the problem is the resources that each clinic uses. So ideally, what we want to have is a venous lead level. That's the type of lead testing that we want to get. But unfortunately, in many cases, when we're talking about, in particular, free clinics, the option that we have is capillary lead levels. So, for example, here in Allegheny, when the enactment was made in 2018, that kids needed to have 2 lead levels before age 2, one of my concerns at that time was, what are we going to do with people who don't have health insurance? And the answer was, the county is going to provide for them. And yes, the county is providing for them, but the county, unfortunately, the health department, what they are offering is those capillary testing, which actually is the same thing that we offer in our mobile unit in our free clinic. The problem with capillary testing, we know, is that it's not completely reliable. So that's where the differences start to come up. If you have an abnormal capillary testing, the recommendation is that repeat another capillary testing. If you don't have the option, ideally for a venous lead level. And then if you have 2 abnormal capillary lead levels, then you have to get a venous lead level. And right now, as far as I know, we don't have an option to cover for those venous lead levels for people who don't have health insurance. So right there, you have a big difference. Another difference is, as Rebecca pointed out, and I will let Rebecca elaborate on this, is the background, the support that families have when they have health insurance, whether it's private or whether it's Medicaid. They have case workers. They have people looking after them. They have people getting the results from the report, people calling them and telling them, you got this abnormal result in case your pediatrician haven't called them yet. How can we help? And then, we can go from there. But one of the biggest problems, and one of the first problems that we have, is how those lead levels are being obtained. So right now, yes, we have to get those 2 lead levels before age 2 in Allegheny County. The difference is, if you have insurance, whether it's private or Medicaid or CHIP, most likely you're going to have a venous lead level, or at least you have the option for that in case you have 2 abnormal capillary lead levels. But if you're uninsured, you have to rely on what the health department offers or what the free clinics offer, which in most of the cases is that capillary lead level. And that is already a problem. And the second issue is that we wish that it was just the lack of health insurance. But we know that that's the tip of the iceberg. A lot of the families who have commercial insurance are the families who live in houses that were built in the 1980s, 1990s. So the chances that those lead levels are going to come out normal are really low. Those are the families who live in the suburbs. But if you happen to have medical assistance or have no health insurance, you most likely are renting in the city, and those houses are being built before the 1970s, and those houses have a lot of paintings, and the risk for exposure is much more higher. And as you mentioned before, the type of items that they are going to be on the environment are probably a higher risk. It's different when you buy a toy in a commercial store versus something that you buy in a cheap store or secondhand, and that might be problems. And then the other thing is that sometimes the families who belong to minority groups are new immigrants to our country. We are used to in this country that lead was eradicated from the environment in the 1970s when the laws were enacted. We have on lead gasoline. We don't have any more lead painting. Well, unfortunately, that's not the reality for the rest of the world. Many of us watched the news from Afghanistan and how many we were receiving immigrants from Afghanistan, refugees. Well, it turned out to be that Afghanistan still have lead. They're not on lead gasoline. There is not on lead painting. So we have to be careful of these families, and that's one of the biggest differences are.
So, Kevin, what are you finding, like in the Philadelphia area? Are there, how are you managing? Like, are you able to test folks that don't have insurance? Are you running into the same scenarios as Diego? Is there something in place?
Yeah, I think all of the issues that Diego brought up are statewide, and they're really humanity-wide, right? There's not a level economic playing field, and there's a lot of environmental injustice. And, it goes to a little bit of what we were saying about awareness of lead, right? But lead isn't the only issue that families in poverty face, right? In my colleagues in my own academic division, right? It's easy for me. I'm the toxicologist. I'm the lead advocate. I say lead is bad, lead is bad, lead is bad, and want everybody to listen to me. I have a colleague who says hunger is bad. I have a colleague who says firearms are bad. I have a colleague that says interpersonal violence is bad. I have a colleague that says lack of access to good education and schooling is bad. And, truth is all of those things are bad. And the challenge comes when you face a lot of them, right? Because, for all of us, our ability to attend to issues becomes narrowed and we choose priorities. And so, up to the testing point, when you have a patient and they're in your office and you can't get a capillary level and you need to send them for a venous level and they need to go to a laboratory to get that done, there are barriers at getting to that laboratory to get it done. And you let a family know that they have an elevated blood lead and that you want them to come back in and you want them to work on that. There are barriers to that. And so, I think that there are a lot of places in society where we need to work on a lot of issues that are all interrelated as they come to lead and how it's harmful to us.
Rebecca, do you have anything to add to that?
I think that there is a challenge for those that are uninsured and underinsured. I think those two are significant challenges that exist. For children who have Medicaid, we do look at those being challenges that continue because if you don't have food on the table, getting your lead rechecked is going to be the last thing on your list of things to do. It's just the hierarchy of needs, and that if you don't have certain things in place or taken care of, those things are going to fall to the side. So we have at Gateway, the things that we have in place to assist members is we really take into account the social determinants of health to ensure that members have access to food and they have access to shelter. We have utility programs that we look at to assist the families first. And then we look to ensure that we are getting these other things taken care of. So we do try to take into account the whole person centered approach before we're throwing them into this realm of, okay, well, now you have to get a lead test again. We want to make sure that they have all of these other things in place. We have the ability to give them transportation where the public transportation or the state funded transportation falls short because we know that medical assistance transportation won't take a family places or they won't take a car seat places. So we've put things in place that allows us to work with transportation vendors that will help a family or take the car seat or take the mom to pick up the kid from daycare or preschool and then take them to their appointment. So we've gone these extra routes to make sure that we're able to help the family get these other things in place, because without those other things, lead and those healthcare needs are really going to be at the bottom of the list. So we assess, we look at these other things in addition to trying to make sure that they realize the importance of lead in the scheme of everything else going on in life. the past 18 months have made that really difficult, but we're starting to kind of get back into a little more of a realistic point of, okay, things are kind of getting back to a more normal trend in getting these levels. Our levels are higher now from what we're seeing, but the frequency of kids getting checked is starting to get back to where we saw them pre-pandemic. So we do have to make sure that now, that the utility moratorium's over, that these, families aren't getting their utilities shut off, because if you don't have the lights on and you don't have heat, who cares if your lead level's high? So we have to make sure those things are in place first, and then work to make sure that the home is safe overall from lead. So we make sure that we are working with the families for those things.
I know one of the things that's been helpful, because again, sometimes for whatever reason, services aren't always utilized, or it's not the right time for the family. And I get that. But I also think that for Allegheny County, what's been helpful was they have, and she spoke in one of the panels earlier, Juanita Brown, who works for the health department, and she provides that bridge. She reaches out to families that have come through the health department, for children that have tested, at 5 and above. And she reaches out to them directly to kind of talk about not just early intervention referrals, because some families, especially if they're resistant or hesitant or not interested, but also how families can access home inspections. And she kind of does that warm handoff, which I think has really helped. And I do notice that, they're collecting data on terms of, at least for the early intervention piece, who would want that service. Are they already in services, or if they decline? But I think it's been helpful to have someone spend that little bit of extra time. And I realize time is a commodity, right? I mean, I think in our pre-gaming, Kevin, you talked a little bit about maybe not always having like the amount of office staff and support that you need to have extended conversations, right? To have maybe some of these bigger support conversations, or some of the follow-up piece. And if I have this wrong, I apologize, but I think that's also, something else that everyone is facing in terms of some staffing crunches and other things that have kind of come to the surface. So how do you make those referrals, or what kinds of services are you, as far as, the medical practices that you're part of and what you're doing, ensure that families at least have that information? Like, how does that look from your end?
So there are many ways to do this. So one is we have after discharge summaries, after visit summaries that have printouts, and fortunately we can have access to different languages of these materials, and we can actually preventively give information about lead even without knowing what is the result, and we can actually start planning even before we even draw the blood. I really appreciate, Karen, your point that you make about the shortage on staff. Right now, because of the pandemic, other priorities have come first. So right now, vaccination is one of the priorities. Everybody's preparing for next week when the COVID vaccines are going to be approved for 5 to 11. And right now, even before we have reached that point, unfortunately, lead, hemoglobins, screening tests had become a lower priority, and they shouldn't be, actually. It's really sad, because a lot of times I wonder how much we're truly helping our families if we're missing these important opportunities. As Kevin said, we have kids that might have been exposed for lead for many months, and we only know until we have that blood drawn, and if we don't draw that blood, it's going to prolong the problem. So right now we're facing difficulties. We have a shortage on staff. Everybody's aware about this. It's in the news every day that there's a shortage of nurses. Nurses are choosing to go to better pay salaries jobs. They go to work in nursing homes. They work to go sometimes in the hospital. Hospitals are offering signing bonuses. But also is the fact that the pandemic has changed everybody's life. So some people have chose to retire. Some people are afraid about contracting the disease and they prefer to stay home, which is completely understandable. We all are in the same boat. But again, unfortunately, because of all these changing conditions, lead now has become a lower priority. In our practice, we have a system where we have, for example, pre-May fax letter to refer, for example, to early intervention. We have a system to put orders in our electronic medical record, so the lead dwelling inspections on the homes are made. We have at hand the phone number from the Allegheny County Early Intervention Program and from the health department to make those calls. What I will tell people who are listening to us, and this is actually what I teach, I was listening what Kevin was saying in terms of teaching the students, the residents, the next generation, but for everybody who's here, sometimes it's as easy as just Google, early intervention, birth to 3, Columbiana County. I mean, I do this as a developmental behavioral pediatrician with people who come from different counties, from different states. So just as simple as Googling, finding the number, and making that call. That's true for early intervention. That's true for the health departments, and that's one of the first steps. And when we're short on staff, we have sometimes to take some jobs in our hands. And if I had to make the calls, I make the calls. The hardest part is sometimes getting those blood draws, because, as I mentioned before, unfortunately, right now they are not the priority. I'm not saying that they shouldn't be the priority, but right now they are not. And I cannot even imagine how it's going to be next week when we're going to be doing COVID vaccination for 5 to 11. Definitely is going to be a lower priority. It shouldn't be. Ideally, we should have resources for everybody, but that's the reality.
Okay. Kevin, you had mentioned thinking about the environment, keeping kids preventing them from getting further exposure. Do you have any mechanisms for following up with families, or how does that look for you guys? Or, I know that you're not driving to people's homes and doing physical assessments, but is there follow-up that comes when you that you're on your work, or things that you would recommend doing that might be helpful?
Yeah, I think every single doctor, nurse, pharmacist, social worker that's involved in this wants to do the right thing. And unfortunately, we've made it so hard to do the right thing. How do you find who your helpers are? How do you find who's got expertise in doing environmental assessments? How do you find all these programs? And so, again, Taylor in the chat put in a website of a toolkit that's very useful. It's got all the numbers right there in one thing. So you can kind of look and say, I'm in this county and these are the numbers I need to call. And that's very useful. For me, it's if I want to prevent the lead, I have to figure out where the lead's coming from, and that requires taking an environmental history. In medical school, or at least in the medical school I went to, nobody really taught me how to take an environmental history. It certainly isn't something that is emphasized. And so I would point out that the American Academy of Pediatrics, along with the American College of Medical Toxicology, with a grant from the ATSDR, have created a network of pediatric environmental health specialty units. That's abbreviated PEHSU. I can put something into the chat. And they have an open classroom, and they have a free webinar, 1 hour. It's 1 hour well taken on how to take an exposure history. And when people see that and think about it and can do that exposure history, I think it goes a long way to kind of figuring out what types of resources are needed for these children. And then the toolkit helps you to find those resources to get it through. And that's the part that still remains a challenge. If we have people like Rebecca who are able to champion for our patients and make sure they get the resources that they need, it's so wonderful. And like Diego said, sometimes you have to take matters in your own hand. But what do we do when we have a child and we know that they live in a house that has a lot of lead hazards, and we know that they have repairs that need to be done, and we need to figure out, well, where can we relocate that child temporarily? Where can that family or that landlord find the money to get the work done? I think those are the things that flummox your average office pediatrician who's got 16 other patients in the waiting room waiting for them, and where the assistance is really needed.
Well, and I would say for any of your Medicaid patients, all of the Medicaid MCOs have someone who is here for that very reason. So those types of cases can always be referred out to the Medicaid liaisons that are listed in this very handy resource guide. I think we're all listed in there, and that you can refer those cases to us and let us be the ones to worry about them, so to speak, because that is we have dedicated units for just that reason, to follow up on those members, to ensure that they are getting those lead investigations and helping you to figure out where it is that we can find those resources and get the remediation taken care of. So at least for the Medicaid population, that's what the MCOs are here for, is to ensure that those pieces are kind of getting in there and to ensure that the coordination is done. So not many, but most offices, some offices have lead nurses that our care coordinators and case managers work with to kind of make sure all those pieces get kind of aligned and in place. We work closely with all of the ones that we have a liaison with, whether that's the new Lancaster County lead program. We have contacts in many of the larger offices. So we assign like the same person to each of those offices, so a relationship gets built to assist with those very issues.
Sorry, I lost my cursor there for a minute, and my cat scratching at the door, and I have a stink bug flying. But other than that, I'm awesome. So I think, and it's back to kind of what I said earlier with Kevin's talking about the environmental history. Like, if you're not asking the right questions, you're never going to get the answers that you're looking for, right? So I think that's huge across all things. And I think, I think I've learned, like, I've had the opportunity of being in many, many, many homes over the years, and you learn many things from just walking in someone's home and kind of being in their environment, right? So I think without having that experience, but having the opportunity to kind of talk a little bit about that within the basis of routines, right? And collecting that environmental and also that developmental information and kind of how that goes together, I think can be really significant, because as Kevin put in the chat to say everybody benefits with a strong advocate in their corner. And I think we also understand the way that, people learn. You have to hear things more than one time, and you might need different ports of entry, and something might, having like repeated conversations might make that stick for you. So I think that is really helpful to keep in mind. So thank you for sharing that information about the webinar. I know we've talked a lot about what like communication and follow-up could look like when it's, a recognized above 5 and maybe eventually above 3 to 5, having that conversation. But do those conversations look any different for families that have a level of 3 or 4?
Yeah, I think a lot of the times we're thinking, okay, what is the threshold? And we're talking about that is now 5 and it's going to be 3.5. And everybody, like in anything in life, want to make sure that you don't meet that threshold. And if it's 4 and if it's 3 right now, or in the future, if it's 2 or 1, people are going to say, oh, I don't have to worry about this. And actually what we need to change is that mentality, because there is not a normal lead level. And we have talked about this throughout the day, has been emphasized the importance of knowing that. And as Kevin mentioned, it is important to know that the more that we have the lead level in the body, the more it's going to be affected. So I think what we need to do is education. I really like the idea of Kevin of doing this environmental histories, try to assess what is the risk, put a lot of emphasis on prevention, and then go from there. Yes, if we have a level that is above the trigger level, of course, there are going to be things that are going to be, there are more things that we're going to have to do, where is there a referral to intervention or the follow-up visit. And then I want to emphasize for those who have to deal with these decisions, there is 3 guidelines, and it's part of the toolkit that it was shared. And also the Allegheny County, the health department has some specific guidelines that probably are going to change with the change on the threshold number. But when do you have to do the next follow-up, in 1 month, in 3 months? For Kevin, in his area of expertise, when do you have to chelation if the levels are much more higher, 20, 40, 50? When do you have to consider even admitting the child? But again, I think we need to start thinking about that. 1, there is not normal level, and 2, what kind of education we're going to start doing in terms of preventing this exposure. And it should start when it's 1, 2, 3, regardless of the other actions that we need to take.
Thank you for that. And I know from just an early intervention standpoint, it's really sometimes tricky for those families that call in and they have a level of 3 or 4 and they're concerned, right? So the early intervention, the at-risk tracking category begins at 5 and above. That was actually just changed in 2016 for us. That was a huge piece of our state verification, making sure we were doing outreach, which we have. But I feel for those families that call in to our intake office, and what we can offer them. Any child under 3 that wants an early intervention, full developmental evaluation can have that. I mean, they may not necessarily be eligible for services, but they do have that opportunity if they want to have that full evaluation. But there really isn't that space for those kids that come in at 3.5 or 4. And at that point, like what I would typically do is recommend them to another child serving, arena, family support center, or, a quality early childcare setting, or something else that is going to meet that need and monitor a child's development if a family is concerned about that. And the other thing I was thinking too is I'm just wondering, for those kids that are not getting screened, is it also that they aren't making their well child checkups as well, right? So they're not getting other immunizations. It's not just lead. That's just sort of like the tip of the iceberg concern, right? So I think and what I'm seeing now, which I haven't seen for a while, and it makes me feel very sad, is that just in the last couple weeks, I've seen a referral come through for a child with a level of 28 and one with 32. So I don't know what's happening, but that's concerning. So I would just say now, we may end up finishing up a little earlier. I think we're all in agreement that we have more work to do, but we are certainly, if you're here this evening, you're interested, you want to be an advocate. Hopefully you found some things that will be helpful to you. And I appreciate the champions on the panel, but I'd just like to know, are there things that, in particular, that you would like to share out, or people to know that you think are helpful in terms of things that they can implement or, do tomorrow at work that might be different than what they're doing now?
So I will say it's really important that we support these organizations that are making the advocacy work. If it wouldn't be for efforts at the legislation level, at the advocacy level, we wouldn't be talking about this now. We will start dealing with lead in our country. Unfortunately, we have in many levels like a level in our country, but it's not true for many countries around the world. And while it's not in many parts of the environment, it is still a risk for many kids. So we need to support these organizations who are advocating for better health, for screening, for preventive measures, and at the end, for better guidelines. Bringing the lead level from 5 to 3.5 is an advance. And as we have mentioned before, one point that I want to make sure that everybody knows is that there is not normal lead level. So even 1 or 2, we need to start thinking about what can we do to mitigate that number. The second point, I mentioned before, the importance of having universal health insurance. We need to address barriers to healthcare access. Kevin talking about everything that we can champion as pediatricians. If you have one commonality, is poverty. Poverty is one of the biggest issues that is affecting many of our kids in our country. And then having access to healthcare is really important as part of how can we address the problems of these families. So we can truly have universal healthcare in Pennsylvania for all the kids. And what I'm asking is not necessarily something that is completely out of this world or out of this country. I'm not even talking about other developed countries like Finland or Denmark. I'm just talking about other states like Illinois, Massachusetts, California. We should start thinking about having truly universal healthcare for all our kids in the state of Pennsylvania. And we need to work together. The pandemic has shown us how important it is to work together, that we cannot leave anybody relegated, anybody behind. And the fact that we have other priorities right now, like, for example, COVID-19, doesn't mean that we need to forget prevention. And as part of prevention, we need to make sure that we screen for lead and we address the kids who have high lead levels. And it is true, Karen, I really appreciate your comment. There are many kids who are not going to a doctor. They are not getting their vaccines. They're not getting the lead screenings. It is a problem that we have, and we need to address it. And the only way that we're going to address it is we address it together. Physicians alone cannot do it. Early intervention programs alone cannot do it. Insurance alone cannot do it. We need to work on this together. Thank you.
Yeah, thank you very much, Diego. And we're focused on lead, and I don't want to upset any of the lead advocates who are on the meetings. But a lot of times we talk about this in the concept of healthy homes, and for me, the environment is much bigger than lead. I've been working on lead for 30 years. Frankly, politicians, advocates had kind of letting it fall off the map until the Flint, Michigan episode brought it back to national consciousness, and people all of a sudden started to have money and started to have bake sales and things to work around lead, which has been very welcomed, and it's led to webinars like this one and efforts throughout Allegheny County, and it's been so welcomed. But there are a lot of other hazards in our children's environments that we need to consider. And so as we're working through our environmental history and our advocacy, it's worth thinking about all of those other things. And it's also important to think about opportunity costs when we make a move. What do we lose, and what are some of the evils that we don't know? So at one point in time, there was a lot of little trinket jewelry that was be sold at little markets we've talked about. They were cute, and you might want to buy them for your kids, but they were made out of lead. And so we realized, okay, that's lead, that's bad. And so we banned the lead in them, and they started shipping them in with a metal called cadmium, which isn't necessarily any better. I would posit is probably worse. It just isn't as well studied, right? And so all of these things are in our environment. Climate change requires such attention from everybody on this, and we need to work together. I agree with Diego. We need to work together. Thanks.
I think there's so many things it's hard to, like you said, kind of know where to focus your attention, right? And if you are focused here, then what else is falling off? So how do we kind of level everything and bring everything together, right? How do we do that? And I don't have the answer. Rebecca, how about you?
I don't think I have the answer either, but I do think that continuing to advocate and learning new ways to work together and understand that there is a way to utilize the health insurance agencies, particularly the Medicaid MCOs, to assist the physicians in getting members what they need, so that the physicians have more time to focus on the sick kids and not putting pieces together that we can do for you. And knowing that we can also assist with those other pieces like the social determinants of health that are so important to ensure that families have time then to worry about the little things like lead, because if you don't have food on the table or the lights on or the heat on or the water on, those other things don't make a difference. So ultimately, we all want to work together to ensure that we can assist in getting those things taken care of so that mom and dad can worry about the lead levels, because those things are going to be important in the long run.
Thank you all. We're going to end a little early. I think many of us have had a full day, or you've had a full day, even if it wasn't here, it was still probably full. I appreciate your time, attention, and advocacy. I think that our panelists did an excellent job of highlighting some of the concerns and also some of the strategies in terms of, including that environmental history, kind of thinking about other things that are impacting children's health and well-being, and thinking about the overall safety of a community that really makes a difference. And we understand that while this is our focus today, it may not be a family's focus. So, helping us to kind of continue these conversations and really be advocates. So I want to thank Rebecca and Kevin and Diego for the work that you're doing and the work that I know that you'll continue to do. And it was an honor to host this panel and be a part of this. So thank you so much.
Thank you so much for having us.
Yeah, thank you, Karen and Rebecca. You guys inspire me, and so many people here do, and make it all worthwhile. So thanks for the work that you're doing. Really appreciate it.
Thank you.
And Karen, thank you for a great moderation. You did a great job with a difficult topic. And I also want to thank the people who behind the cameras, all the people who put together this panel, Taylor, I'm forgetting names, but I'm pretty sure they know who they are. So thank you for everybody who worked on this.
Yeah, Taylor, Hannah, Michelle, everyone at Women for Healthy Environment, the Coalition, the Lead Safe Allegheny. This has been a really It's been a great event and bringing people together. And I think you feel energized when of course, when you have people that are already believers, right? And then you have to like take the message out and kind of continue to do the work. So thank you all. And thank you for folks that attended this evening. And I wish you good health and a lovely evening.